for joining us this afternoon for the American Liver Foundation and the Canadian Liver Foundation's webinar on Wilson disease, genetic testing, and emerging treatments. My name is Warren Hall. I'm the National Manager of Support Services at the American Liver Foundation, and I will be the co-host and co-moderator for our afternoon for the webinar today. Also co-hosting and assisting with the webinar is Nem Maximovic, who is from the Canadian Liver Foundation. And so he's my counterpart here. And so we're both very happy to be able to organize things here. Today, we're going to be joined by three speakers, two of our medical experts who will be discussing genetics, medications, and emerging treatments for Wilson disease. And we'll have a patient advocate joining us who is going to provide us with some real life input into what her life has been like with Wilson disease. And perhaps many of those who are on the webinar with us will be able to associate and certainly benefit from what she has to offer. So our agenda today is that we'll have the three speakers who will begin with their talks. And then after the speakers are finished, we'll move on to the Q&A aspect. Now, what we'll ask you to do is to, as the webinar goes along at any time, you can put in your questions that you may have. We know some folks forwarded their questions to us ahead of time, and that's wonderful. And if you wouldn't mind, you can definitely put those questions in again so that perhaps live during the webinar today, we'll be able to answer those. And just so you're aware that this webinar is being recorded. And so therefore, it will be available in the next few days on the American Liver Foundation website, which is www.liverfoundation.org, as well as the Canadian Liver Foundation website, which is www.liver.ca. And these will also be available on the various YouTube and Facebook pages. So the American Liver Foundation provides educational programming, advocacy, support services for those with liver disease and for their families, for caregivers. We do this through various educational programming such as we have today. And so right now I'm going to turn it over to my co-moderator, co-host here, Nem, who will say a few words about the Canadian Liver Foundation.
Hello and good afternoon all. Again, as Warren was mentioning, thank you all for attending today. For those of you who may not be familiar with the Canadian Liver Foundation, the CLF, short for Canadian Liver Foundation, we were established in 1969, and we're the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars: research, education, patient support, and advocacy. So as Warren mentioned, today we are joined by our three presenters. We have Dr. Eve Roberts from the University of King's College in Halifax, Nova Scotia. We have Dr. Nadia Ovchinsky from the Albert Einstein College of Medicine at the Children's Hospital at Montefiore in New York City, New York, and Amy Totte, a Wilson disease patient advocate. So at this time, I would like to welcome our first speaker, Dr. Eve Roberts. Dr. Roberts, as a quick biography here, trained at the Royal Free Hospital in London, United Kingdom, and became a pediatric liver specialist and researcher at the Hospital for Sick Children in Toronto, Canada. She was the clinician on the team which identified the gene abnormal in Wilson disease and has written extensively on Wilson disease and pediatric hepatology. Dr. Roberts is currently an adjunct professor of pediatrics, medicine and pharmacology and toxicology at the University of Toronto, and adjunct scientist in the genetics and genomics medicine program of the Hospital for Sick Children Research Institute. Additionally, she is an associate fellow in the History of Science and Technology program at the University of King's College in Halifax, Nova Scotia. And Dr. Roberts has also served as the chairperson of the Canadian Liver Foundation's National Board of Directors and continues to be a medical advisor and dedicated volunteer. and I will hand it over to Dr. Eve Roberts for her presentation.
Well, thank you very much for that very kind introduction. I'm delighted to be here, and my first task is to present some cases, which we'll use in addition to our patient advocate to organize our discussion today. So I must tell everybody that these are fictional patients, and as they say in the movies, if there's any resemblance to real persons, it's totally by accident. The first case is a 22-year-old man who's been referred to a hepatologist by the Student Health Clinic at a nearby university because he was found to have some jaundice and abnormal liver tests in his blood. So as we were saying, so this is a 22-year-old basketball player at a university who's got some jaundice and maybe had an episode of jaundice before, but otherwise he's a well, healthy, well looked after young man. The questions go sort of like this. How's your appetite? Are you eating well? You can see he does. Do you drink more alcohol than the average university student, which I've noticed to be quite a lot? And he doesn't do recreational drugs. Occasionally, he takes a high protein mix to improve his muscles, and school is going all right. When you ask him about his basketball game, he gets really excited. It's tremendous. He says that his coach says that he's Iceland's answer to Steph Curry, although he allows that he's giving up quite a few turnovers. So the hepatologist says, well, does that mean you're from Iceland? He says, no, my dad's from Iceland. And your mom? Well, she's Czech. And is there any liver disease in your family? No. Do you have brothers or sisters? Yeah, I have a sister in high school. Physical examination shows a tall, skinny, muscular Caucasian man who looks like a basketball player. He's not jaundiced. And by the way, his BMI is quite respectable for an athlete. His eyes appear normal. There's a hint of yellow at the edges of the whites of his eyes. And the only thing which is important here is that his liver is a bit enlarged and can be felt below the right rib cage. His laboratory data shows that his hemoglobin is somewhat low for a young man of his age at 12.2 grams per deciliter, but the other blood counts are fine. His liver tests really are abnormal. As you can see, they're running in the mid-hundreds. His bilirubin is high. The conjugated part that reflects liver damage is also a bit high, but otherwise things are pretty good. So an abdominal ultrasound exam is obtained, and this shows a homogeneous pattern. That means it doesn't look like cirrhosis, and it's consistent with fatty infiltration, and everything else is okay. So as a hepatologist, you have to formulate a list of possible diagnoses. Some of these are relatively benign, and some of them are not. Wilson disease is one which is not. So some tests are done for Wilson disease, and as you can see, the serum ceruloplasmin is low. The serum copper is a bit on the high side. The reticulocyte count, which is a measure of new red blood cells, is higher than normal. And the basal 24-hour urinary copper excretion is high at 192 micrograms per 24 hours. So this is consistent with Wilson disease if it's greater than 40. A slit lamp examination is done to look for Kaiser-Fleischer rings, and none is found. So the question is, do you do a liver biopsy now? Do you do genetic testing? Well, one thing a lot of people do at this point is to put these data into the Leipzig score to help you make a diagnosis of Wilson disease. And you get points for various features that have to do with Wilson disease. So this patient gets nothing for KF rings, 0 for neuropsychiatric, although you could question the clumsiness if that's why he's giving up turnovers. There's the question of a hemolytic anemia. The urinary copper qualifies for 2 points, and the serum ceruloplasmin qualifies for 2 points. And you end up with a score of either 3 or 4, and that really doesn't help you very much. What it means is you have to investigate further. So do you do a liver biopsy at this point, or do you examine the gene? And it makes sense to examine the gene. And that's what they did. They sent off for genetic testing. It was done competently. And it turns out that this young man is a compound heterozygote. His genotype shows 2 different disease-causing mutations. The 2007 del7 is the common Iceland mutation, and H1069Q is common in Eastern Europe. So this genotype is disease-causing. He's got Wilson disease, and he gets started on treatment. So what about his sister? His sister is a completely healthy 16-year-old, and in fact, she's an Olympic quality long track speed skater. Her physical exam is normal. She doesn't have KF rings either. And the liver tests, though, are somewhat abnormal. And her basal 24-hour urinary copper excretion is elevated. And so you immediately turn to a genotype test for this girl, and it turns out she has the same genotype as her brother. So that means she also has Wilson disease. So to recap, the first patient is a young adult who gets transient jaundice with abnormal liver tests and maybe fatty liver. And his genotype shows 2 disease-causing mutations. He has Wilson disease and he's symptomatic. His sister also has Wilson disease, but she is asymptomatic, though she has biochemical evidence of organ damage. So she also starts treatment. So those are the cases. And now I'm going to move to the talk about genetic diagnosis in Wilson disease. Well, first of all, I want to say how grateful I am for the opportunity to participate in this webinar. And as you might expect, I'm speaking to you from Nova Scotia, Canada. So let's take a historical approach to this matter of genetics in Wilson disease. This is the beginning of Wilson's 1912 paper in Brain, Progressive Lenticular Degeneration. It didn't become hepatolenticular until the early 20s. So this was published in 1912. It was actually his MD thesis. It's a 200-page paper. For those who want to try to put this into perspective, the other important event of 1912 was the launch and sinking of the Atlantic. And this time is well depicted in the first season of Downton Abbey. So now let's flash forward 40 years. This is the paper of Watson and Crick, published in Nature in 1953, disclosing the structure for DNA. And really, when you think about it, it's really quite interesting that many of us cannot recall a time when we did not know that DNA is what our genes are made of and that it has this characteristic double helix structure. Now, let's move forward another 40 years. This is the cartoon from the paper by Bull and colleagues in Nature Genetics in 1993, describing the gene which is abnormal in Wilson disease. It was known that Wilson disease was associated with a single gene. It looked possible to identify that gene in the late 80s, and this paper represents at least 5 years of work. You can see that the gene was put together like a jigsaw puzzle with overlapping bits of DNA to define it. It was helped by the publication of the Menkes gene, which is just above in this cartoon. The 2 genes are very similar, and they encode enzymes which transport metals. These were the first such enzymes found in humans, but they are common throughout all forms of life. And now I think we should still say that this gene, which was originally called WC1 and then renamed to ATP7B, is in fact the only gene which is associated with Wilson disease. And here's an artist's conception of what this protein, which is encoded by this gene, might look like. As you can see, it spans a membrane, and it runs on ATP energy. This is sort of the engine that takes in that energy, and it has this very interesting tail with numerous areas where copper can bind to the amino acids in this tail. This protein does at least three things. It moves copper across membranes inside the cell, and in the liver cell, this is to make enzymatically active ceruloplasmin. However, when there's too much copper in a liver cell, then this protein starts to the process by which copper is moved out of the hepatocyte into bile. And therefore, we can see that there must be a sensing function as well, so that the protein knows whether there is or is not too much copper in the cell. So why was it important to identify this gene? There was some thought that this was such a rare disease, why put so much effort into it? But the fact is, we got a real handle on Wilson disease, and we began to understand the physiology of how various metals, mainly copper, are handled in cells. The work was really led by Diane Cox, whose picture is here in the lower corner of this slide. She was visionary in the way she pursued genetic research, and she firmly believed that a genetic disease needs a genetic diagnosis and a genetic treatment. And we all believed that with her. And I'm not about to say that that was a misplaced belief, but by the end of the 90s, it became evident that genetic diagnosis was not as straightforward as we thought it was going to be, and figuring out how to design genetic treatments was also not easy. So what can we say about this question in 2021? Well, what we've learned about this particular gene has made it possible to make secure diagnoses of Wilson disease. And more recently, it's made it possible to develop mutation-dependent treatments, either ways to restore the function of defective ATP7B protein or to repair the gene itself. What it has not permitted us to do, and what it has not given us, is a crystal ball so that we can predict the character or the course of the clinical disease. And we know that it's been important to have genetic diagnosis because clinical diagnosis can be difficult, mainly because Wilson disease can present in so many different ways, as liver disease, neurological disorders, psychiatric disease, neuropsychiatric problems, with different patterns in all those disease categories, and extrahepatic patterns of disease. For example, in the patient we presented, recurrent breakdown of red cells, recurrent hemolysis. So let's back up for just a moment and talk about genetic patterns of inheritance. We say that Wilson disease is an autosomal recessive genetic disorder. So autosomal recessive inheritance means that you need two significant, which is say two disease-causing gene changes in the disease-associated gene to get clinical disease. As you know, here's a karyotype from a male. This gene is located on chromosome 13, and you get one chromosome from your mom and one from your dad, broadly speaking. So if you have the same mutation on each of those chromosomes, then you are homozygous. You are homozygote for that mutation. If, as is most often the case in Wilson disease, you have two different mutations, one disease causing on one chromosome and a different disease causing mutation on the other, then we call you a compound heterozygote, but you do have Wilson disease. In contrast, if you have only one disease-causing mutation and the other chromosome is entirely normal, then you are a carrier. You don't have Wilson disease. You're clinically well, and we could even use part of your liver for a liver transplant. It gets confusing because sometimes we talk about carriers as being simple heterozygotes. That's quite different from being a compound heterozygote. So what is the risk of, as it were, getting Wilson disease? Well, this has to do with the prevalence of Wilson disease in the general population and how many people in a population are carrying one or more mutated genes. So we now know that the prevalence of Wilson disease is generally about 1 in 30,000. In some places, it might be rarer, like 1 in 50,000, and in others, it might be more frequent. For example, in Sardinia, it's about 1 in 10,000. And of course, this will also influence the prevalence of carriers, people who are totally healthy but do carry one mutation. And we can ask what increases the risk, which really is to say, when do we see more of these mutations? Well, first of all, geographically limited populations. For example, islands like Iceland, or the Gran Canary Islands, or Kalymnos in Greece. Also, isolated mountainous areas, for example, in Romania, have been seen to have increased numbers of patients with Wilson disease. Marrying within your kindred. So first cousin or second cousin marriages are problematic. And then there are what I'm calling culturally bounded groups. These are groups which by cultural means encourage marriage just within that group, thus limiting the gene pool somewhat. So if we have a genetic diagnosis in Wilson disease, which is to say, we ask the question, is this gene ATP7B completely normal, or does it show variants? And then we can use this for a number of different situations. First of all, we can use it to clinch the diagnosis. And this is important if you have confusing or not particularly classic clinical and biochemical findings. If you do a liver biopsy and for some reason the copper in the liver is not as high as you expected it to be, or if there are extenuating circumstances which make it difficult to interpret the clinical and biochemical data. Or, as happened with our patient, if you have an incomplete Leipzig score, or one which doesn't absolutely make the diagnosis for you, then doing the genotype will clarify the situation and give you a very positive score. Some people want to use genetic diagnosis just to make the diagnosis. I call this the cut to the chase strategy. So you think you have a patient who has Wilson disease on clinical grounds, and instead of investigating copper metabolism, you simply investigate the gene. This is definitely the most efficient way to investigate first-degree relatives, brothers, sisters, mothers, fathers, offspring. And again, with our patients, the sister was easily diagnosed by doing a genotype evaluation. Not so commonly, but perhaps increasingly in the last few years, where we have genetic investigations in the context of infertility studies. A couple may be genotyped for Wilson disease, and it may be determined that they are, for example, both carriers. In that case, one can do a genetic diagnosis on the infant to make a neonatal diagnosis of Wilson disease, or indeed no Wilson disease. And as it will become apparent, some of our gene-based treatments will work for certain genotypes and not for others. So it will be important to get a genetic diagnosis to assess suitability for certain treatments. What are the limitations? Well, first of all, ATP7B is a really big gene. And this makes it difficult to investigate. And this is probably why in many series you see that a certain percentage of patients don't get a definitive genetic diagnosis, even from the best labs. There are many different ways to investigate this gene. They have to be used in a complementary fashion. And we had thought that high throughput methodologies such as whole exome sequencing or whole genome sequencing would solve all our problems. It's important, but it can miss certain kinds of mutations. Another problem is that there are approximately 700 gene variants, with more being described every year. And some of these are established as disease-causing, but some are not. So you could get a report for your genetic diagnosis of a pathogenic variant on one chromosome and a variant of unknown significance on the other. So we have both in the lab and in the computer ways to characterize variants of unknown significance, but it can be very labor intensive and it's not always satisfactory. And then finally, the gene is not the whole story. We know that what's going on in the cell can influence the effect of a mutation, whether it is disease-causing or not. We think there are modifying genes, but we haven't really found very many of them. And we think that external environment might have an effect. For example, with twin studies where you have monozygotic identical twins who both have Wilson disease, but one has a very different life history from the other. These are still unsolved problems. Moreover, recent genetic research raises the question of whether Wilson disease is as rare as we think it is. A number of population-based genetic studies have identified more individuals who should have Wilson disease than are actually diagnosed as having it. In one of the first of these studies, the prevalence of individuals with a genotype for Wilson disease was put at about 1 in 7,000 instead of the usually accepted 1 in 30,000. And that's not the only study to make that kind of assessment. Other studies have looked at the prevalence of carriers and found that they're more prevalent than we thought. Now, there may be methodological problems with some of these studies. Some of them are too small to be really reliable. Some of them have used perhaps an inadequate definition of disease-causing mutation. But there may be true heterogeneity in populations, and we're still learning about that. Another possibility that's been raised by these studies is variable gene penetrance. The discrepancy between Wilson disease that you ought to have on the basis of your genotype and Wilson disease that you do have on the basis of clinical assessment is somewhat inevitable for a number of reasons, which have to do with ascertainment, people getting sick with other things. There are problems. But all of our theorizing is based on the idea that if you have the genotype for Wilson disease, sooner or later, you will have clinical Wilson disease. When we ask if there's variable gene penetrance, then we start to question that assumption. For example, could it be that what regulates the effective gene expression is something in the environment? Maybe there are epigenetic factors. Or maybe there's a time dimension to gene expression and certain variants are regulated in a way that changes over time. This is an emerging area. There's no firm opinion about this issue, but it's an important issue and it poses important challenges for medical management of Wilson disease. So to wrap up, Wilson disease genetics. Wilson called this a familial disease, but remember, he was at a tremendous disadvantage because he didn't have technology or even concepts relating to genetics or inborn error of metabolism in the early decade of the 20th century. We know that the gene that's associated with this disease is ATP7B. It has numerous mutations. I think the really important take-home message is that genotype analysis can establish the diagnosis of Wilson's disease and is often the most efficient way to make the diagnosis. However, The analysis can be fraught because the gene itself is very complex. And I think we can speculate very constructively that knowing the genotype will be essential in the future because it will influence our choice of treatment, which may be geared to specific mutations. I'm sorry for the technical difficulties, and I thank you for your attention.
Thank you, Dr. Roberts. That was really wonderful. You got us through 100 years, over 100 years of Wilson disease history in those few moments, but fascinating. And I think what's great about that is the idea that it's evolution. It's, a continuing study and uncovering. So really, thank you so much for that. So now it's my honor now to bring you all south of the border being the border between Canada and the United States. And I'll bring you into New York as I welcome our second presenter today, Dr. Nadia Ovchinsky. Dr. Ovchinsky is Director of Pediatric Hepatology and is the Medical Director of Pediatric Liver Transplantation at Children's Hospital at Montefiore. She's also an associate professor of pediatrics at the Albert Einstein College of Medicine in New York City. Her clinical focus is on the treatment of children who have liver disease, and her special expertise is caring for patients around the time of liver transplantation, preparing them for a successful transplant, and then managing their recovery afterwards. Dr. Ovchinsky's research interests include improving the quality of care and enhancing the delivery of care for children who have chronic liver disorders by developing non-invasive techniques to predict outcomes in children with liver disease and optimizing long-term outcomes of pediatric liver transplantation. Her work has been presented internationally at various lectures, and she has published numerous peer-reviewed journals, books, and review articles. And so, Dr. Ovchinsky, I now turn the program over to you.
So today, after a wonderful talk of Dr. Roberts, I'd like to focus on treatment options for patients with Wilson's disease. We'll talk about current therapies, and then we'll talk about some emerging possibilities. So I'd like to go back to our cases. So what are some of the treatment options for our symptomatic 22-year-old patient? And what about his sister, who is still asymptomatic, but does have evidence of liver damage? Do they need special diets? Can they continue with their lives and their elite sports at this time? So let's dwell into some of our options. So treatment considerations in Wilson's disease include lifelong pharmacological therapy at this time. With lifelong therapy, we'll also have lifelong monitoring for effectiveness and for some of the treatment-induced side effects. We have some choices for our patients for primary treatments that we will discuss. So chelators, which help remove copper from the tissue itself versus zinc. Is there any role for combined therapy? Is there any role for liver transplantation? And finally, we'll talk about some of the interesting emerging therapies. So the first oral agent for treatment of Wilson's disease was actually introduced in 1956, and it was penicillamine, and it's something that we still use readily today. This is a chelating agent, so it helps remove copper from the tissues and promotes excretion of copper in the urine. It gets absorbed from the GI tract really rapidly, and it cannot be given together with a meal because that reduces the absorption of the medication by about 50%. So we have to be careful and use it either an hour prior or 2 hours after the meal. Unfortunately, the medication still has significant side effects. Neurologic symptoms may worsen in up to 50% of patients, and in a third of the patients, we actually need to switch therapy and discontinue penicillamine due to side effects. Some of them can be seen early on, such as rash, fever, inflammation in the lymph nodes, and lower white blood cells and platelets. Some of them can be seen later with treatment, such as effect on the kidney or bone marrow, muscle disease, polymyositis, and even liver toxicity from penicillamine itself. So a newer chelating agent, triantine, was introduced in 1969, so there's still quite a few years of experience with it. It also works by removing copper from the tissues and promotes copper excretion by the kidneys. Neurologic worsening is less common with triantine than it is with penicillamine. And we see a much improved side effect profile. So many patients who cannot tolerate penicillamine will do pretty well with triantine. Although we do see side effects, including decrease in all types of cell lines. Again, it cannot be given together with a meal because it will decrease the absorption. Another therapy, zinc, acts quite differently. So what it does is it blocks the absorption of copper, our dietary copper, in the gut. It induces a special protein, and this protein has affinity for copper and it binds it. And when it binds it, it prevents copper from entering through these intestinal cells and entering into the bloodstream. And in fact, some of the intestinal cells can also lose copper and then it gets reabsorbed. But if this protein is induced by zinc, then it also prevents reabsorption of this copper. So much of the copper gets excreted in the stool and it doesn't get absorbed in the gut. So it's a little bit different. It doesn't chelate, it doesn't remove copper from the tissues as effectively as chelators, but we're still getting rid of quite a bit of copper. The main side effect is gastric irritation, and again, you cannot take it together with food. There is a newer chelator agent. It's called tetrathiamolybdate. So this is a very promising agent because in addition to removing copper from the tissues and helping the liver disease, it actually does not worsen neurologic symptoms like the other chelators do, or at least to a lesser extent. So it's useful in liver disease, but it's also a drug that may be useful in neurologic disease for patients. It's been in clinical trials, and I'm actually very excited because clinical trials will now include children 12 years and older. It's not yet commercially available, but we will hear more and more about this type of chelator. So what about diet? Diet is important, especially in the beginning, especially in the first year of treatment, but also lifelong. There are certain foods that should be avoided, such as shellfish, liver, nuts, mushrooms, so foods that are very rich in copper. And we'll also have to be careful about water containing copper, as well as using some cookware that contains copper. So what are some of treatment recommendations that we can give to our young male and his sister? Well, initial treatment for symptomatic patient should include a chelating agent, either penicillamine or triantine, depending on side effect profile. Patients should avoid intake of foods and water with high concentration of copper, especially during the first year of treatment. And then when we're dealing with asymptomatic patients, our 16-year-old sister, or those who have already been treated and they can now be on maintenance therapy, this can actually be accomplished with a chelating agent or with zinc alone. In pediatric patients, more and more, we are now favoring zinc as the initial treatment in asymptomatic patients or as maintenance therapy. So what are some of the special considerations for treatment? Let's take patients with decompensated cirrhosis. So this means that patients have advanced liver disease. These patients often don't make proteins the way they're supposed to make proteins. They may have fluid in their belly or ascites. They may bleed from very large esophageal or gastric varices. What do we do with a group of patients who are sicker than general patients with Wilson's disease at diagnosis? Well, there's a potential role of dual therapy with this group of patients by using both a chelator and zinc. And then with effective response, potential transition to monotherapy can occur after about 3 to 6 months. Unfortunately, with this with this group of patients, there's a high risk of drugs not working very well. And then these patients should be evaluated for liver transplant as the only potential therapy. What happens in pregnancy? So the recommendation is to continue Wilson's treatment. It's very important. But given the fact that we don't know all the risks to the developing fetus of chelators, and in addition, there's some risk of poor wound healing in the postpartum period, it's recommended to reduce the dose of chelators. But zinc can likely be maintained without any dose adjustments. And finally, there's a role of liver transplantation in a subset of patients, first in patients who present with acute liver failure, and then also in patients with decompensated cirrhosis who could not respond to regular chelation. In the last decade, our patients with Wilson's disease did experience sort of a crisis situation where patients ended up without being able often to obtain therapy that they needed to obtain. So what happened is that the cost of chelator therapy went from about $1 per pill in the early 2000s, and then in 2014, 2015, Valeant Pharmaceutical had raised their prices. They raised their prices for both penicillamine and especially for Triantin or Cyprin to $200 per capsule with an annual cost of almost $300,000. So this made it one of the most costly treatment of liver disease in the United States. The crisis also occurred in Canada when earlier on, Cyprin was available via special access program, but then the cost became prohibitive when the prices were raised. So communities of patients and communities of liver specialists did a lot of advocacy. There were significant efforts, they were written about in medical journals, as well as New York Times, and there was even a Netflix documentary that had focused on this subject. And Dr. Roberts, our co-speaker, was actually a very important person advocating for patients with Wilson's disease during this time. In 2018, a new generic came out by Teva. However, in the United States, we were very disappointed because although it was cheaper than Cyprin, it was still $18,000 per 100 pills. Well, we're in a much better place today because Triantin is now available as a generic in both US and it's starting to be available in Canada as well. And the cost is significantly cheaper, as low as $8 to $10 per capsule. So let's talk about targeting gene expression itself. The idea of gene therapy, or a type of DNA-based medicine that can replace a mutated gene variant, was first published in 1970s. And there were many, many years of disputed results and different experimental trials. And we are likely in the very beginning of ages when we're able to apply this therapy for patients with liver disease. So the process of building protein, including our protein that we're going to talk about today, begins with DNA. So cells first read the instructions contained in the DNA, and then they make a copy that's called an RNA. And then the cells read the instructions in the RNA and they create a protein. This is a little bit of a more familiar concept now that people have heard so much about COVID vaccines and RNA technology that it's a pleasure talking about this to patients now. So what happens is that in many rare diseases, there are mutations. So there are changes in the code or letters of the DNA, right? So this is how the mutation occurs. And then when RNA reads it, then obviously the mutation is transcribed here, and then it gets translated into a mutant protein. So this protein does not function well because of the mistake or mutation in the DNA itself. Well, there's genetic medicines, right, that are called steric blocking oligonucleotides. So these oligonucleotides are short stretches of DNA or RNA. They can actually bind to a specific place in the RNA. And by doing so, they modify the natural way in which the cells process RNA and build proteins. So they can correct the protein itself. They don't make any permanent changes to DNA itself. And once this medicine, this genetic medicine washes out, then it no longer has any effect. So there's no permanent change in the DNA. So the exciting news is that oligonucleotide therapeutics may be applicable to a subset of Wilson's disease patients with certain identified targeted mutations. And these mutations can actually be identified by artificial intelligence, a pretty complex but exciting technology. These are expected to be studied for certain patients with Wilson's disease in the near future. They will need to be injected subcutaneously every 2 to 4 weeks. Because remember, it's not a cure, but it's a very effective therapy because it can provide, while it's attached to that RNA, it can provide lasting benefit by increasing the protein in the liver that we need. So what about gene therapy? Well, gene therapy aims to correct the defect itself in the native cells by providing healthy copies of ATP7B. There's usually a vector, an inactive or harmless viral particle that introduces a transgene. The transgene is able to be targeted to the liver, where the transgene can then integrate into liver cells themselves and can potentially persist and stay as integrated part of the DNA. So this option may allow ATP7B to be permanently expressed in hepatocytes or liver cells of patients with Wilson's disease. And imagine with this concept, it may eliminate a need for lifelong intake of copper-reducing drugs. It's administered by single IV infusion, and there are certainly risks that we need to consider. Including immune reaction, including what if it cannot incorporate into sick hepatocytes or sicker liver cells. And certainly we need to learn lessons from ongoing trials with gene therapy that are currently applied in hemophilia and sickle cell disease. But the exciting news is that clinical trials are expected very soon for patients with Wilson's disease. So in summary, there's treatment for various clinical profiles. Medical treatment for Wilson's disease at this time is lifelong, requiring also ongoing monitoring. Liver transplantation is an option in certain special scenarios, but it's an exciting time in clinicians who treat Wilson's disease because there are novel therapeutic approaches. So we can either potentially offer a less toxic suppression of copper accumulation removal or correction of the mutant function of the protein itself. These are promising and they could be available shortly to patients with Wilson's disease. Thank you.
Thank you for that great presentation overview, Dr. Ovchinsky. Very very engaging in terms of treatment and some emerging treatments. I think it's very exciting for all the listeners out there. I would like to now invite our third speaker, Amy Totte, Canadian Liver Foundation peer support volunteer and Wilson disease advocate, to share her journey with Wilson disease. Again, we encourage everybody to still stick around. We are going a bit over time, but we're definitely going to have a very engaging Q&A session following Amy's discussion with all our panelists. So use the Q&A box in the bottom, and we'll be looking forward to your questions shortly. I will be handing it over to Amy.
Hi, everyone. I just want to actually just start off by thanking the Canadian Liver Foundation and the American Liver Foundation for inviting me to participate in this webinar and share my story. There we go. So my story is my personal journey through Wilson's disease. And this is a little bit about me. So I am 33 years old. I live in Manitoba, Canada, the northern Manitoba, Canada, where there's still some snow. I'm married and I have 2 young children. I have a 5-year-old daughter and a 3-year-old son. And before things kind of happened with Wilson's disease, I was actually a dental hygienist, and I still am. So back to July 2019 is when things started to change for me. So I was at work at the time. I started to notice I had a large stomach. I had a son at the time who was a 1.5 years. And actually I would have coworkers come up to me and friends and ask me if I was expecting a gain. And I wasn't. So I would actually get asked almost weekly. Another thing that I started to think was a little strange was I had amenorrhea, which is I didn't have a menstrual cycle, which I did see a physician about, and she thought maybe it was just had to do with recently having a baby. So I was also experiencing very severe mood changes. My family doctor was thinking that maybe I had a form of personality disorder. She referred me to a psychologist and he diagnosed me with severe anxiety and depression. So they knew something was going on with me mentally. I also started to see little red spots, petechia, which on this photo, it's actually on the top of my foot. I would just, look down at my feet one day and I would see these little red spots on the lower legs and on my feet. And I was also very tired. I was exhausted. I was working and I had 2 kids. So and everybody else just thought it had to do with being a working mom with 2 young children. So in July 10th is the day I actually made the phone call and called my regional health links here in Manitoba. I spoke with the nurse and she actually was the one to advise me to go to the local emergency room. Being where we live, we don't have clinics that are open in the evenings or weekends. So the emergency room was the only place that was open at the time, and strictly just because of the marks on my feet and my stomach, she was a little concerned. So she wanted me to get checked out. So that evening in the ER, they did some blood work and they found that I had very low platelets and I had abnormal liver enzymes. So I had a high AST, a high ALT, my INR was elevated. And so they knew there were some things going on and they just didn't know what it was quite yet. So they actually asked me to come back first thing in the morning when the ultrasound tech was available, and they were going to do an abdominal ultrasound on me. So the next morning I returned to the same hospital. I had an ultrasound. They found advanced liver cirrhosis. And they immediately scheduled me for an endoscopy and an abdominal CT scan. So they were trying to figure out what was going on. Why did this, young mom with 2 young children, why does she have such a terrible looking liver? So they asked me a lot of questions, the nurse and the doctors. They asked if I was heavy into alcohol, if I had any piercings or tattoos, hepatitis. They looked at my figure and I wasn't overweight. I was, if anything, at that time, I was actually a little bit underweight, minus the belly. Asked if my history of whether or not I was taking any large amounts of Tylenol for a large period of time, and if I had any family history of liver disease. And the only thing at the time that I could think of was I actually do have a grandma who passed away from liver cancer at the young age of 43, but the cause was never determined. So they made note of it and started to do some tests. So at the emergency room, the people who I was talking to was an actual an internist. He was the head of the hospital who came in and was speaking to me, and he worked alongside with a gastroenterologist. So they were extremely thorough. They were great. They did another bedside ultrasound to confirm things, and that's when they decided to screen me for Wilson disease. At that time, when they were doing some additional blood work, they decided to also send my blood away for genetic testing. So while all this is going on, from that day in July, I was referred to a hepatologist where she actually discovered that I had elevated liver enzymes from 2015. So that was actually when I was pregnant with my daughter. They did some just basic blood work when I was pregnant, and that's as far as they could find. I was never one to go into the doctor clinics very often. So I was also referred to an ophthalmologist where they did a slit eye exam. At that time, when I did see the ophthalmologist, they found the Kaiser-Fleischer rings present, and they also discovered the sunflower cataracts in my eyes. My abdominal CT scan, they found that I had an enlarged liver and an enlarged spleen. I had ascites, which was the enlarged, stomach that I had, and portal hypertension. So when I had my endoscopy, I did not have any varices present, which is wonderful news. They were very happy about that. And because I had the Kaiser-Fleischer rings, they wanted to do brain MRI. So I also had that done, and they did not see any significant findings with the brain MRI. And with my blood work, they found low ceruloplasmin, low copper serum, and my 24-hour urinary copper was extremely high. I believe at that time it was about 500 and something units. So from July until September, having all those tests done, it was quite busy. A lot of traveling, going from where I currently live to the cities where I can get the testing done. I was officially diagnosed with Wilson's disease on September 5th, 2019. Due to having the rings present in my eyes, and also because of the extremely high 24-hour urinary copper levels that I had. So my hepatologist started me on penicillamine, actually that very day. So my genetic report actually came back on September 17th, 2018. It was positive for Wilson's disease, and it confirms what the gastroenterologist and the hepatologist had diagnosed on the 5th. So fast forward today, April 2021, I have gone from decompensated liver cirrhosis back in July of 2019 to now where I'm sitting, I am in compensated liver cirrhosis, which means that because of the medication that I have been put on, the penicillamine, my liver is actually functioning quite well for everything that it's been through. My current symptoms right now, I do still suffer from chronic fatigue. I get tired very easily, so I have to take breaks. I also might be having some peripheral neuropathy in my fingers and my toes, specifically my fingers, a little bit of tingling. I do get some memory loss issues. Some days are better than others, and that also might have to do with some children. I still actually have a very enlarged spleen. So they keep an eye on that with 6-month ultrasounds. And I also have low platelets because of the enlarged spleen. My platelets generally sit about between 45 and 60. I do experience some sleep issues. I have trouble sleeping. But that's always a work in progress. And my mood varies as well. It just depends on the day and everything else that's going on. So I'm aware of it and everybody else is. So going back to family inheritance, so like I said, my grandma on my father's side, she passed away at 43. I actually was unfortunately never able to meet her. But my dad and his siblings have told me all about her. She, growing up, my dad says she always complained of having stomach pain. She was always back and forth to the hospital. She had a large belly, and when she passed, they actually ended up finding some liver cancers. So, but they never explored it any further than that. So we don't have any confirmation that it was Wilson's disease or not. It's just one of those things that are in my history. So no other family members with known Wilson's disease are in my family other than myself. My mom is a carrier and my dad is a carrier. They were both unaware until my diagnosis. My mom is actually still in denial about it, but the way that the genetics works, I've explained this to her numerous times, that it's just what happens. My brother is also a carrier. So when I was getting diagnosed, he actually had his blood and urine and ophthalmologist checks done as well, which all came back as negative, and he had genetic tests done. They used my genetics to go along with it with my permission, and so he is only a carrier. He only has one of the changes in the gene, the mutations. So, and my lovely children, my daughter, she's 5 years old. So she has had, they both have had all their blood tests done to check for liver function, platelets, everything like that. My daughter's is all coming back normal. And she also has had the 24-hour urinary copper test done, and that's been normal as well. My son, he has normal blood tests, and he had an abnormal 24-hour urine test. He's had 2 abnormal urine tests. He's 3 years old. So right now, this is still ongoing for me. I'm currently waiting any day for a phone call for a referral to a pediatric gastroenterologist to find out what the next steps are for both of the kids. So these are my current goals. My current goals is you always want to take care of yourself first and foremost, right? So I am continuing to improve in my own health. I take all my medications as directed. especially my penicillamine. I have it an hour before I eat, and in the evening I have it 2 hours after my supper. I also watch what I eat. I don't eat any of the high copper foods, and I drink, this is Brita water that has been filtered. One of the presenters also mentioned about cookware. So all of my pots and pans, I specifically purchase them to make sure that they do not have any copper coatings inside of them. I listen to my body, how I feel. If I'm feeling fatigued one day, then I know to take it easy so that I can try to get a good night's rest. And I also have a very good relationship with my family doctor, local family doctor, and my hepatologist who I go see. So in terms of goals for my children, I am going to continue to go to each doctor appointment that comes up for them and having any tests done. I'm waiting on that referral for the gastroenterologist, so I'm not too sure what the next steps are, but we'll just take it as it comes. I also am currently monitoring for any signs or symptoms of Wilson's disease. If anything changes with their health, if they start feeling unwell, then I just bring it up with their family doctor. So, and another goal of mine is to be a patient advocate. I really like to advocate for other people, whether that's for people just in the health system, whether that's for people that, have experienced Wilson's disease or they're being diagnosed with Wilson's disease. I want to be the person that they feel that they can communicate with, and, if I can help them, I would love to help them. So right now I'm a patient advisory committee member for the Norman Regional Health Authority in Manitoba, Canada. And I'm also the Canadian Liver Foundation's National Peer Support Network peer supporter for those with Wilson's disease. So if there's any questions from the Canadian Liver Foundation, they know to feel free to call me, email me, and I will try to help them the best I can. And I've also founded the Wilson Disease Support Group on Facebook for Canadians living with Wilson's disease. So in the end, I have a few words of advice for everybody watching. First one is always listen to your body. You know yourself best. You know what's normal, you know what's not normal. At the beginning for me, I knew that my stomach was not normal. I knew that there was something going on. I didn't know what it was, but there was something. So, and that's when, if something is not right, go and speak to a doctor, a medical professional about it. Ask for help when you need it. If that's a doctor, a friend, a family member, anybody, if you're struggling with anything at any point in your life, reach out and try to get help, because there's a lot of people with excellent advice out there who would love to help in any way that they can. Try to connect with others. I found that at the beginning when I was first diagnosed, I did not know a single person with Wilson disease. I didn't even know what it was at the beginning. That's when I started to search out for people that had the same thing as me. I mean, when I have Wilson's disease, it's not the same as another person with Wilson's disease. We all present a little bit differently, but we get to share each other's stories and see what everybody else is going through and help each other. So just know that you are not alone, no matter how rare it is, or, you are not alone with anything. There is somebody out there. And don't forget to live your life to the fullest. When I was trying to get diagnosed, I got stuck in a rut and I was not able to do as much as I wanted with my children. I felt very distracted, but I took a little bit of a step back and I thought, I am going to enjoy each day. I'm going to do something with my kids each day. I'm going to do something with my husband. And we are going to enjoy life, whatever life decides to hand at us. So remember to take each day in stride and just enjoy the journey. So thank you for everyone for listening.
Great, thank you, Amy, for that wonderful patient perspective. I think a lot of the individuals and participants were probably very happy to hear, but can also likely relate to your experience. And again, thank you for sharing the story. I will let Warren, just logged on there, take over on the Q&A, and all the panelists are here, and we will get the question and answer portion going.
Great, thank you. And I want to add my thanks to Amy. You know, it's always so important and encouraging, you know, to hear the patient perspective. And I also want to say that of all the panelists, you handled your PowerPoint presentation the smoothest. You had absolutely zero problem sharing your screen as well as your insights. So there you have that. I'll leave it there. One of the, actually a compilation of a few questions, and Amy did touch on this, had to do with testing of individuals perhaps who are seeking to start a family, those who maybe when women are pregnant, what kind of testing is done? Children who are infants right after they're born, is there testing? We had a few questions in this regard. So doctors or Amy, could you perhaps just address that a little bit? Like, what is done as early as possible to detect if Wilson disease might be prevalent?
Well, I think I could deal with some of that, Warren. It is difficult to make the diagnosis of Wilson disease clinically in a very, very young child, which is to say in the first year of life. That's partly because the regulation of the ceruloplasmin production is not mature. And so that's not a good starting place. We also have questions about early treatment because you need copper to develop in the first year or so of life. So that's a very difficult question. Where it comes up is usually if you already know the genotypes of mom and dad. So, and then the smart thing to do is to test the genotype in the baby. Amy might have been diagnosed in pregnancy, because this does happen, and you can imagine how difficult it is to make the diagnosis of Wilson disease in a woman who's pregnant and has changes in her liver function, protein production, and that sort of thing. Also, there are half a dozen really bad things that can happen involving the liver during pregnancy, and most physicians will be directed to those diagnoses first. But without doubt, Wilson disease is diagnosed in pregnancy, and you might look for the same sorts of problems when somebody's not pregnant. Again, genotype diagnosis might be a really, really big help for that. So the other question which does come up is if you're planning to be pregnant, and you feel that you have a risk of having Wilson disease, this is something you might like to know before you get pregnant. And in that case, I think genotype analysis is probably the best way to go.
And there's no newborn screening, right? For some genetic disorders, there's newborn screening that can identify infants very early on in the first few days of life. There's no newborn screening for Wilson's disease at this time.
No, that's right. And that's because the immediate risk to the infant is not particularly great, whereas newborn screening programs generally look at things which will be really, really severe for the infant in the first few months of life. There have been attempts at general population screening, and thus far they haven't been particularly successful.
Amy, a thought in that regard?
No, not really.
Okay. So a question, can penicillamine be given during pregnancy?
It can be. The dose is generally reduced because of the concerns of some teratogenicity or risk to the developing fetus, and also because postpartum, you need better wound healing. So both penicillamine and triantin can be used at pregnancy with reduced dosages.
Okay, good.
The big problem is that we don't have very large experience. When you try to figure out how many women have been pregnant on one drug or the other, then the statistics are not powerful enough to say anything very definitive. So it is a bit of a guess.
Okay. And another one, my elder daughter is 9 with Wilson disease. I have a younger one who is 2. I've done genetic testing for elder daughter, husband, and myself. Should I go for the genetic testing for my younger one too, based on the sequencing of my elder one?
Well, I would.
Okay.
You know, you have the data you need to make an interpretation of a genetic diagnosis. And if you procrastinate, I mean, it's not like something that has to be done tomorrow, but this would make sense to use a primary genetic diagnosis.
Okay.
Don't you agree, Nadia?
Yeah, absolutely.
Yeah.
Okay. And a question here. What happens with the petechia? Is it bleeding or is it just a redness?
It's from having low platelets.
Okay.
The petechia is skin findings that we get from having low platelets, which is secondary to an enlarged spleen that eats up many of the platelets in the body.
Okay. Good. Okay. Okay, so I think we'll stop there in the interest of time with questions. So we will get to the questions. We have them, and we will get a response to the folks as best we can. But thank you, everybody, for submitting your questions. And I will now turn things back over to Nem.
Thank you, Warren. Again, thank everyone for attending. We did go a little over time, but I think we were able to address some of the great topics and questions that everyone who attended had. And like Warren mentioned, we are more than willing and likely to answer some of the outstanding questions that we didn't have time to answer today, whether that is reaching out to our experts and asking them the question and seeing if we can get that answer to you directly. There's some other information here that Warren is sharing in terms of how to contact and connect with us. We do thank everyone for their questions. And of course, a big thank you to our medical experts, Dr. Ovchinsky and Dr. Roberts, for the great presentations. And a special thank you to Amy for sharing her journey with us as well. And most importantly, to the participants and the listeners out there, the entire ALF and CLF community for tuning in. As mentioned, this webinar will be available on both the American Liver Foundation and the Canadian Liver Foundation Facebook pages, websites, and YouTube pages over the next few days. Should you have any questions in terms of how to find it, where to find it, our emails, of course, are listed, and you can always reach us on our website. So that's the liverfoundation.org for the American Liver Foundation and the liver.ca for the Canadian Liver Foundation. Again, to learn more about Wilson disease and all other liver diseases. And finally, please be sure to follow us on social media. We have quite a bit of social media channels where we try to stay up to date with some of the most up-to-date information on liver health tips. And finally, we do want to thank everybody for listening and have a safe and wonderful rest of your day and evening.